We are Group 1, and the following presentation will describe the management of the patient, Joe Cruz, following his transfemoral amputation. Here is the outline for the following presentation. Overall, our objective for this presentation is for the learner to understand the overall management of a young, highly active patient following a transfemoral amputation. The patient is a 20-year-old Hispanic male. He is a private in the U.S. Army. He was involved in an IED explosion 1 month ago, which resulted in a right transfemoral amputation and right eye enucleation. His BMI is 25.8, and he smokes 1 pack of cigarettes per day. His hobbies include hunting, fishing, and working on cars. He has also been diagnosed with PTSD. He has been prescribed Vicodin for his pain, and his anticipated length of stay is 4 weeks in inpatient rehabilitation, followed by ongoing outpatient rehab. This slide outlines the critical patient history that will have an impact on clinical decision-making regarding the patient's plan of care. First, looking at demographics, the young age of the patient is a factor that will positively affect prognosis. The patient is also in the Army, which can indicate a high level of motivation as well as a high level of fitness prior to amputation. The fact that he is in the Army also indicates that he is insured through the VA, which is another positive factor affecting prognosis. The social history of the patient indicates that he is a smoker. Smoking can impair and slow the ability for proper wound healing. The patient's previous level of activity will likely correlate with the level activity the patient will have the goals of returning to. Because we know that the patient is planning to return to a home that requires ascending 14 stairs to enter, an inclusion of stair training needs to be an important part of the patient's plan of care. The patient may also require work with a case manager or social worker to find ADA-accessible living arrangements. One of the patient's current conditions includes a right eye enucleation. This greatly affects the patient's vision and should be considered when establishing patient goals and establishing the plan of care. We know that the patient has been prescribed Vicodin for pain. Therefore, we need to know whether the patient has taken this medication before his physical therapy session and obtain a pain rating, because the amount of pain that the patient is experiencing will greatly impact his ability and willingness to participate in physical therapy. The patient has a medical diagnosis of PTSD. It is important to know what triggers his PTSD, because the triggering of PTSD can have an adverse effect on the patient's mental and overall health.
Here we will begin the examination of Joe Cruz. We will perform a generalized systems review to help rule out any potential red flags or medical complications that could hinder the progress of physical therapy goals. The cardiopulmonary screen will include heart rate, blood pressure, respiratory rate, temperature, and lung auscultation. The patient is at risk for pulmonary complications due to recent hospitalization and smoking a pack of cigarettes per day. A general visualization of the skin at incision sites, looking for improper wound closure or excessive bleeding. For cognitive status, we will use the Montreal Cognitive Assessment, which has shown a statistically significant association with functional mobility. A 2016 study showed people with lower scores on the MoCA took longer to complete the L test. Information on baseline characteristics of pain, taking note on amount and whether pain is incisional, and here we will take the opportunity to educate on the potential for phantom limb pain. A 2006 article determined the MCID for pain in a patient with an amputation is 1.8 points on the NPRS. A DVT check is done due to recent surgery and immobility, checking pedal pulses on the unaffected extremity and femoral pulse in the affected for circulation, as smoking 1 pack of cigarettes per day is a risk factor associated with vascular compromise. It will be important to track changes in weight and body composition for this patient, as there are clinically significant increases in weight shown 1 year after amputations in a military population. We will assess integumentary integrity at the incision site as well as throughout the body, especially in areas subjected to increased or prolonged pressure. We will assess sensory integrity, including proprioception and protective sensation, as to avoid future complications in the unaffected extremity. We will want to make sure that the patient has sufficient range of motion in the residual limb. Sufficient hip extension is necessary for balance and is a prerequisite for fit into a transfemoral prosthesis. Gross range of motion in the intact limb and upper extremities at all major joints will be important to optimize mobility for the patient. We want to measure muscle performance in the upper extremities and lower extremities, taking precaution to avoid increased pressure around potentially sensitive areas. Good strength in the hip extensors and hip abductors is another prerequisite for fit into a prosthesis. To assess functional mobility, we want to assess the patient's ability to move to and from a variety of surfaces, as well as aerobic tolerance to such activities for which we would use an RPE scale. We can assess sitting and standing balance to determine physiological response, tolerance, and any potential compensation strategies that the patient may use. The Activity-Specific Balance Confidence Scale, or the ABC, can be used to measure changes throughout the plan of care and to quantify fear of falling. Joe had surgery to remove the right eye due to trauma faced during the explosion. As a result, we will look to assess any associated visual field deficits for placing of objects throughout treatment session and possibly providing compensation strategies and/or assistive devices.
In addition to any outcome measures that may be utilized in the previous section to document progression for increasing functional levels, more specific questionnaires and performance-based tests can be documented. For inpatient rehab, therapists could use the Locomotor Capabilities Index, which is a subjective self-report questionnaire with 14 items of ambulatory skill capabilities as perceived by the amputee, regardless of whether or not they are currently wearing a prosthesis. For outpatient, there are many more options for outcome measures that have been designed with the amputee population in mind. As such, the Validated Prosthetic Limb Users Survey of Mobility 12-item short form can be used, which is also a self-report questionnaire on perceived level of overall mobility from household movements to outdoor recreational activities. The Activity-Specific Balance Confidence Scale is a similar self-report outcome measure assessing an individual's confidence in mobility and standing. The Comprehensive High-Level Activity Mobility Predictor, or CHAMP, and the L-test are both performance-based outcome measures that would be utilized in the outpatient setting. The L-test should be a familiar measure to perform with a total of 20 meters walking, 3 turns, a sit-to-stand, and a stand-to-sit. But the CHAMP is a newer test specifically designed for amputees who have the potential to perform high-level activities. These are 5 smaller tests encompassed in the CHAMP and range from a single-leg stance to the Illinois Agility Test, pictured here. According to a study performed in 2013, the CHAMP demonstrated a strong positive relationship with a 6-minute walk test and with the amputee mobility predictor. We anticipate Joe to eventually function around the Medicare functional classification level of K3. Primary factors for this categorization include the following: 20 years of age, normal limits for BMI, invested VA medical insurance, and expected leisure activities upon discharge, such as hunting, fishing, and working on cars.
The patient has a right transfemoral amputation with a medium residual limb length. He also has an absent right visual field due to his right eye surgery. He smokes 1 pack per day and drinks 6 drinks per day. He has pain at both surgical sites and describes the pain as a 5 out of 10. He also has phantom limb pain that he describes as burning and also a 5 out of 10. He has no signs and symptoms of infection at either surgical site and has intact sensation except directly around the surgical incision site of the residual limb. He has decreased global strength in his lower extremity of 4 out of 5 and upper extremity as 4+ out of 5. Range of motion is within functional limits. Balance is also decreased as evidenced by an ABC scale score of 75%, indicating he is fearful of activities but not avoiding activities. The patient has difficulty with lower extremity dressing. In particular, he cannot don and doff his pants while standing and must perform a supine bridge to pull them all the way up. He ambulates with crutches independently, but requires minimal assistance for bed mobility and transfers, especially when rolling towards the right side and transferring to a chair from a bed due to decreased balance. He has difficulty fishing, hunting, and working on cars while standing, and he is unable to return to work as a U.S. Army private.
Here is a list of the positive and negative factors contributing to Joe's outcomes. He is only 20 years old and a private in the U.S. Army, meaning that prior to the amputation, he was active, physically fit, and driven. He has been diagnosed with PTSD and has lost his right eye, also resulting from the explosion, which can have a negative impact on how he performs and responds to therapy. Being so independent and capable prior to the injury may be interpreted as a negative factor as well, because he will experience a relatively greater loss of independence than someone who may not have been as active. Contextually, he has TRICARE, which is a very well-paying insurance. His mother and military family provide him with a very good support system. However, he currently smokes and drinks, which can delay healing and impact his overall health. His mother's apartment is on the second floor, which will require him to navigate 14 steps with his prosthesis in order to be independent.
Based on the patient's pertinent medical history and surgical status, he would be classified under the APTA's practice pattern 4J. The Guide to Physical Therapist Practice states 80% of patients within this category should require 15 to 45 visits of PT over a 6-month time frame in order to achieve optimal functionality. Utilizing the anticipated examination findings with the positive and negative contextual factors, the patient has an overall favorable prognosis to achieve his goals following physical therapy. It is worth noting, however, that due to past drug use, current alcohol consumption, and prescriptions for painkillers, monitoring the patient for signs and symptoms of central nervous system dysfunction and potential abuse should be incorporated.
Joe will need to have a wrapping program in order to prepare and shape the limb for proper prosthetic fitting. This wrapping program will include the use of ACE wraps, ensuring that there is no adductor roll to give the limb a conical shape if possible. Joe will use a shrinker after the sutures have been removed to further help with limb shaping and to reduce swelling. The type of prosthetic that we recommend for Joe is the X3 above-knee prosthesis as pictured. The X3 is waterproof and rust-proof. It is a sea leg that is battery-powered, therefore he will need to charge it periodically. The microprocessor knee is included to monitor the leg's position in space and naturally adapt to Joe's movement during gait. This will allow him to start and stop gait and change speeds naturally. The hydraulic knee provides flexion and extension resistance and is independently controlled by 2 control valves. The knee is relatively light and weighs 3 pounds and 12 ounces. The leg is supposed to be able to work for around 5 days between charges and contains an inductive charger that will allow Joe to charge easily through clothing. Dynamic stability control will allow Joe to change directions quickly and step forward, sideways, and backward as needed. This leg will also allow Joe to run, walk backwards, walk over obstacles, and navigate stairs using a reciprocal pattern. These features will allow him to ambulate with less compensations, and this will reduce the energy expenditure associated with gait. The leg also comes with 5 different activity modes, such as biking and golfing, that will allow Joe to participate in sports and other leisure activities easily. This is perfect for the young, highly active person. A vertical shock carbon foot was selected for durability and is designed to provide enhanced shock absorption and torsion resistance. The foot is designed to be used during everyday walking and also sports participation. It can also adapt to uneven terrains, which will be important for the patient because he enjoys hunting and fishing. The foot only weighs between 655 and 840 grams and has interchangeable gel heel wedges, so it can be individualized to Joe's preferences. The foot will provide unrestricted outdoor gait and is appropriate for the patient that is classified as a K3. Initially, the socket that the patient will need is a seal-in liner suction socket. Once he enters the stable phase, Joe will need an elevated vacuum socket. We will start with the Össur Ice-Ross Seal-In XTF liner. The movable hyperbaric membrane will allow Joe to move the membrane to achieve the best and most comfortable fit. It can also help maintain fit for patients that experience volume changes throughout the day. This is appropriate for someone that is classified as a K3. Then Joe will move to an elevated vacuum socket because this will allow him to have a closer fit, which will provide increased proprioception, increased control, and less shearing. A mechanical pump will also change the suction as needed to accommodate changes in position and residual limb volume during the day. This will be appropriate when Joe moves to a more permanent prosthesis after his residual limb shape has become more stable. The socket will be created by a prosthetist using a digital limb scanner to achieve the best fit. The socket will be a total contact socket with ischial containment to contour to Joe's residual limb shape. An intimate fit will be important to achieve an adequate amount of suction to hold the prosthesis onto the residual limb. A carbon fiber material will be used for durability and strength.
These short-term goals for Joe are designed to be accomplished by the time the patient is fitted with the early post-operative prosthetic. Patient will demonstrate improved pain on the NPRS scale, decreasing pain at surgical sites to 3 out of 10 from 5 out of 10. Patient will be independent in skin care, wrapping, and positioning to demonstrate proper residual limb care. Patient will stand within parallel bars with minimal sway for 2 minutes times 2 in order to demonstrate improved static single leg balance and increased confidence. The goals for the long term are extended 2 weeks after Joe's discharge from the inpatient rehab facility. Patient will ambulate with early post-operative prosthetic and with minimal tactile or verbal cueing for 250 feet times 2 to demonstrate learned gait mechanics and improved aerobic conditioning. Patient will don and doff pants independently and standing in order to demonstrate improved functional balance. Patient will stand to work on cars for 30 minutes to encourage return to activity.
Here is a list of interventions that will be performed by the physical therapist in inpatient rehabilitation. Progression of exercises will be discussed, including some progression into outpatient rehab interventions. Extra emphasis will be placed on the highlighted interventions. According to Eckhart et al., patients with traumatic amputations are at risk to increase their BMI in the first year after the surgery, partly due to increased adiposity. Therefore, it is important for the patient to exercise to prevent these changes. In addition, this patient is relatively active and endurance training will help him maintain this active lifestyle. In a study by Chin et al., military personnel who had transfemoral amputations were able to improve aerobic capacity after 6 weeks of exercising at anaerobic threshold. The anaerobic threshold may be estimated as 85% of age-predicted heart rate max, or 170 beats per minute for Joe. Subjects were required to exercise on the recumbent bicycle for 30 minutes at or around this heart rate for 3 to 5 days per week. The non-affected leg, or in Joe's case the left leg, would be the only leg required to pedal. Joe would be able to perform this task in inpatient and outpatient rehabilitation to improve and maintain aerobic endurance. In outpatient, once he had become accustomed to his permanent prosthesis, he may incorporate other exercises such as walking or elliptical at the same target heart rate. Mirror therapy may be used to help decrease Joe's phantom limb pain. In a study by Yildirim et al., the patients performed 20 to 25 minutes of mirror therapy at least once per day. They were set up in the manner displayed by the picture and instructed to constantly look at the reflection as they made consistent, symmetrical movements with their lower extremities. The patients were also extensively educated on the benefits of mirror therapy. After 4 weeks, subjects decreased their NPRS pain values significantly from an average of 5.09 to an average of 2.30. Joe will be instructed to perform mirror therapy in the same way described above. It is also important to address mobility and transfers with the patient so he is able to stay as active as possible. The patient may need minimal assistance with bed mobility, specifically having trouble rolling to the right side due to pain. The patient should be educated about changing positions to prevent skin breakdown every 2 hours and to lay prone for 2 hours a day to help prevent flexion contractures. The patient will also need minimal assistance with transfers from bed to chair due to fear of loss of balance. Once he becomes more confident with more trials, he should progress towards independence. The patient will be gait trained on crutches directly after surgery. The patient should be able to handle crutches due to previous functional strength. In addition, gait will be more normalized while using crutches than while utilizing another assistive device such as a walker. At first, the patient's residual limb will be wrapped in a soft compressible dressing to allow for easy checking of the incision site. After sutures come out at around 3 weeks, the patient may be fit with an EPOP or an early post-op prosthetic device. This device will be worn during the day and a shrinker will be worn at night. Both devices will control for edema and help shape the limb for permanent prosthesis. Once the EPOP is fitted, the patient may gait train with partial weight bearing through the EPOP and crutches with a step-through gait pattern. Once in outpatient, the patient will progress to full weight bearing with his permanent prosthesis. In addition to standard mobility training, he will desire training to help him perform his favorite pastimes of hunting, fishing, and working on cars. One example of these interventions would be to teach Joe to transfer from standing to the ground and back to standing. By being able to reach the ground, Joe will be able to prepare his fishing equipment and equipment for working on cars. A progression of this exercise would be to transfer to prone onto a scooter once he's already on the ground and practice sliding down the hallway on his back. This progression would allow him to work underneath cars. Another progression of this exercise would be to get to a kneeling position once on the ground with the residual limb protected by a foam pad and practice manipulating a rod or net which would simulate casting. Once able to perform this intervention, Joe should be able to fish off of a beach while kneeling. Another intervention would feature standing at the parallel bars while manipulating a rod one-handed, which would simulate fishing off a dock or a pier. Once able to perform this intervention, he will be able to fish off a dock. With these modifications, Joe may be able to fish and work on cars shortly after discharge from inpatient rehabilitation. While Joe would be able to hunt in blinds, he would need to be able to climb a ladder in order to hunt in tree stands. Starting in inpatient rehabilitation, he could start with left single limb mini squats and progress to step up, step downs with his left limb. Once an outpatient and fitted with his permanent prosthesis, he can begin practicing ascending and descending a ladder with a step-to gait pattern. Once he is able to perform this intervention, he should be able to hunt in tree blinds. In outpatient rehabilitation, once he is fit with a permanent prosthesis, Joe can practice casting and walking while manipulating objects in a variety of environments to facilitate full return to these activities.
Aquatic therapy offers multiple benefits for patients with lower limb amputations. It allows them to improve or maintain their cardiopulmonary endurance without the stress of weight bearing through their residual limb. The temperature of the water relaxes the muscles and decreases the perception of pain, which can promote greater range of motion in the hip of the residual limb. Movements against the water provide some natural resistance, which will be beneficial for strengthening of the muscles. The buoyancy of the water allows for the patient to ease into weight bearing through his residual limb as well. Aquatic therapy is a good way to begin gait training without the stressors of full weight bearing on land. Additionally, it may boost the patient's confidence and mood as it allows him to more freely participate in normal activities. Care must be taken to make sure that the incision site has been fully healed before starting aquatic therapy. In 2012, Nolan implemented a 10-week hip strengthening program for patients with transtibial, transfemoral, and bilateral amputations. The details of the program can be seen on the slide. The results showed that this program significantly improved hip strength for those in the training group. The control group, which was instructed to do the same form and amount of exercise they had been doing the past 3 months, saw a reduction in hip strength. These results indicate that even with unilateral amputations, the intact limb should be trained as well to avoid strength deficits. The study also found that following the training program, 3 subjects with transfemoral amputations were able to run with their prosthesis for at least 20 seconds. Because our patient was previously very active, this training program may be beneficial for his return to higher functioning levels. Single leg balance is important for prosthetic fitting, donning and doffing of the prosthesis, dressing oneself, and gait. A study conducted by the VA has shown that improved balance abilities and confidence are both good indicators for successful use of the prosthesis. Additionally, balance training is extremely important for this patient because he has also lost his right eye during the explosion. Therefore, he will not be able to rely on his vision for balance as before. Core strength is important following limb loss as it is required for transfers and balance. Problems with sitting balance are more commonly seen in older individuals, but if the patient is planning to return to active duty or even just higher level physical functioning, upper body and core strength will need to be preserved.
Joe should be educated about smoking cessation because smoking impedes circulation and healing. It may also predispose him to a non-traumatic amputation in the future. In addition, his excessive alcohol consumption could interact with his medication to cause liver damage and CNS depression. In addition, drinking more than 4 drinks puts him at risk for future drug addiction. Joe is also at risk for skin breakdown, DVTs, and infection due to his recent surgeries and should be educated about all signs and symptoms and prevention methods. He should be encouraged to alert the medical team if these signs and symptoms are spotted.
Other topics for education include the prosthetic fitting process and peer support groups. As the patient undergoes a huge change in his life, it is important that he understands the timeline of the prosthetic fitting process. This becomes a lifelong commitment as a new prosthesis is required every 2 to 5 years under normal wear conditions. The timeline can give him a general idea of when he should expect to visit his prosthetist for fittings and adjustments. Additionally, peer support groups have been shown to be extremely beneficial for patients coping with a limb loss. The Amputation Coalition provides patients with resources for finding support within their area.
The disciplines listed on this slide will all work together to manage Joe's care while he's in inpatient rehab. Physical therapy and occupational therapy will work together to help Joe with balance, strengthening, and endurance training. Therapists will also help with functional training and residual limb care to help with prosthetic fitting. It will be important to refer Joe to a psychologist because he does have PTSD. A psychologist can help him deal with his injury and can also provide medication if it is needed. Nursing will help the physician with Joe's medical management and monitoring. The nurse and physician will work together to monitor his response to his treatment and determine if he needs further medical intervention. The prosthetist will help Joe with residual limb management and provide pre-prosthetic education. It is important to begin this management early to help him cope and to ensure proper residual limb shaping. Recreational therapy will help Joe return to sporting activities and hobbies that he enjoyed before his injury, such as hunting, fishing, and working on cars. The pharmacist will help manage Joe's medications and help find the balance between therapeutic effects and side effects. The dietitian will be important to educate Joe on his diet to reduce his alcohol consumption. It is also important to educate Joe on his diet and exercise so he doesn't gain weight, which could affect the fit of his prosthetic. An ophthalmologist will help with visual rehabilitation and management following Joe's right eye enucleation. The case manager will help coordinate discharge planning and can help Joe find ADA-accessible housing if it is needed. Vocational rehabilitation will help Joe return to work and modify certain tasks if it is needed. All of these disciplines will work together to help return Joe to the highest level of function possible.
The patient will be discharged to his mother's home if he can ascend and descend the 2 flights of stairs safely with his crutches. If he cannot perform this and needs a wheelchair, he will need to be discharged to a single-level living space that is ADA compliant so he can navigate safely. He may need a wheelchair initially to navigate at home and in the community if he is not able to navigate with his crutches. He will also need adaptive equipment at home such as a shower bench and grab rails in the bathroom to help him move independently. If these adaptations cannot be made to his mother's home, then he will need to move to an ADA-compliant living space or a place where these modifications can be made. Occupational therapy could also provide help with at-home adaptations to perform ADLs. He will continue physical therapy in an outpatient setting. In outpatient physical therapy, he will continue with interventions in wheelchair mobility, balance training, weight bearing on the residual limb, reduction of phantom limb pain, and education. He will also receive gait training with the X3 prosthesis. The gait training will include ambulation on level ground, stairs, and dynamic activities. He will continue with his peer support group. This will give him contacts to help him cope with his injury as well as seek advice on home management and recreation following his discharge from therapy. He will continue to follow up with the prosthetist for residual limb management and prosthetic fitting options as he progresses. The patient will be referred to an ophthalmologist, if he is not currently working with one, to work on low vision rehab to compensate for his right eye inoculation. The patient should follow up with his physician for continued medical management as needed. He should continue to see his psychologist for the management of his PTSD. He will also be referred to recreational and vocational therapists to help him with community integration.